Liver cirrhosis. Definition. Cirrhosis is a chronic liver disease characterized by fibrosis and nodular regeneration resulting from hepatic injury ending in loss of normal liver architecture. Pathogenesis. The main damage in cirrhosis is triggered by scarring or fibrosis, which occurs from repeated injuries due to alcohol or viruses. In response to the scarring, liver cells regenerate in abnormal pattern, forming nodules around the scar, irreversible loss of architecture. The scar tissue and regenerated nodules block the flow of blood and bile through the liver, preventing it from working as it should. Etiology: alcoholic cirrhosis or Leydig cirrhosis, biliary cirrhosis, bilharziasis, chronic hepatitis or post-hepatitis cirrhosis, cardiac cirrhosis, cryptogenic or idiopathic cirrhosis, drugs such as methotrexate, INH-methyl-dopa amiodarone, metabolic, hemochromatosis or hepatolenticular degeneration, miscellaneous, severe malnutrition, alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency is a congenital metabolic disease. Alpha-1 antitrypsin is synthesized in the liver. Clinical picture usually in the third decade of life. Emphysema and chronic hepatitis or cirrhosis. Treatment. The initial treatment of alpha-1 antitrypsin deficiency is symptomatic care. Replacement therapy with purified alpha-1 antitrypsin for lung disease, but it doesn't benefit for liver disease. Classification of cirrhosis: etiological classification, morphological, micronodular, macronodular, and mixed. Functional classification: compensated and decompensated cirrhosis. Child's classification to assess the severity of liver cirrhosis. Clinical picture: compensated, asymptomatic or decompensated or manifest cirrhosis. Compensated or asymptomatic, no liver cell failure or portal hypertension. Many patients with liver cirrhosis are asymptomatic for years. The most common cause of death in patients with compensated cirrhosis is cardiovascular disease. Decompensated cirrhosis or manifest cirrhosis: the liver firm with sharp border, shrunken. The liver may be enlarged in early cases, but with progression of the disease it shrinks. Clinical picture of the cause: post-hepatitis, history of hepatitis, alcoholic cirrhosis, history of chronic alcoholic intake, and hemochromatosis, bronze diabetes. Clinical picture of the complications: liver cell failure, portal hypertension, hepatoma may occur. Complications of portal hypertension, hepatocellular carcinoma, and sepsis are the most common causes of death. Investigations: we have investigations for the cause, for hepatitis, hemochromatosis, and etc. as previously mentioned. Investigations for the liver imaging, ultrasound, CT, fibroscan, or hepatic elastography to assess hepatic stiffness as a marker for liver fibrosis. Liver biopsy is the gold standard for diagnosis of cirrhosis. Investigations for the complications: investigations for liver cell failure, lifts, investigations for portal hypertension, investigations for hepatoma, tumor markers, alpha-fetoprotein, and carboxyprothrombin. And then we have child Turcotte-Poe score to assess the severity of liver cirrhosis: 1 point, 2 points, and 3 points. 1 point, it's absent encephalopathy, absent ascites, with serum albumin more than 3.5, serum bilirubin less than 2, and INR less than 1.7. 2 points, we have mild encephalopathy, grade 1 and 2, ascites mild, serum albumin from 3 to 3.5 gram percentage, and serum bilirubin 2 to 3 milligram percentage, INR between 1.7 and 2.3. 3 points, characterized by marked encephalopathy, grade 3 and 4, marked ascites, serum albumin less than 3 gram percentage, and serum bilirubin more than 3 milligram percentage, with INR more than 2.3. A patient is considered to be child class A if he scored less than 7 points, and class B from 7 to 9 points, class C more than 10 points. Treatment: liver damage from cirrhosis can't be reserved, but treatment can stop or delay further progression and reduce complications. Treatment of the cause: interferon for viral hepatitis, treatment of liver cell failure, treatment of portal hypertension, drugs to decrease liver fibrosis, antifibrotic still under trial, colchicine to increase collagen destruction, and penicillamine to decrease collagen synthesis. Then we have hepatic transplantation, which is the best hope, but many patients are not suitable for this procedure. Alcoholic cirrhosis. Etiology: alcoholic cirrhosis develops after more than 10 years of heavy drinking. Alcohol decreases appetite and causes malabsorption, leading to nutritional cirrhosis. Alcohol is converted by alcohol dehydrogenase into hydrogen ion plus acetaldehyde, which is hepatotoxic. Pathology: micronodular cirrhosis, Mallory bodies, eosinophilic deposits. Clinical picture: general clinical picture of cirrhosis, liver cell failure, more than portal hypertension. Clinical picture of the cause: history of prolonged alcohol intake for more than 10 years, alcoholism. Features of chronic alcoholism: GIT, gastritis, hepatitis, pancreatitis, malabsorption. Cardiac, cardiomyopathy. Blood, hemolytic anemia. Immune, recurrent infections. Metabolic, hypoglycemia, hyperlipidemia. Bilateral parotid enlargement. And for CNS, tremors, headache, migraine, and amnesia. Korsakoff's syndrome. Investigations: general investigations for cirrhosis, treatment, stop alcohol intake, general measures for cirrhosis, essential amino acids, colchicine and cortisone. Alcoholic liver diseases: fatty liver, reversible. Alcohol increases fat entry to hepatocytes and decreases its secretion from hepatocytes. Alcoholic hepatitis: it's like viral hepatitis with increased immunoglobulin A, and the ratio of SCOT to SGIPT is more than 2:1, with AST less than 300. Cirrhosis: liver cell failure more than portal hypertension. Then we have post-hepatitis cirrhosis. Etiology: following virus B, C, and D. Pathology of the cirrhosis itself, positive or seen test. Ground glass appearance. Features of chronic active hepatitis. Clinical picture of cirrhosis. Past history of viral hepatitis. Investigations for cirrhosis and detection of hepatitis markers. Treatment: general measures of cirrhosis. Treatment of any chronic active hepatitis with hepatitis B vaccine for prevention. Bilharziasis causes portal hypertension and periportal fibrosis, but not cirrhosis. Liver function remains remarkably good in chronic infection. Cirrhosis with marked fibrosis occur by two mechanisms: antigen-antibody complex or combined etiology with virus C. Hepatic bilharziasis etiology: schistosoma mansoni is responsible for 85% of the cases, while schistosoma hematobium is responsible for 15%. Life cycle: adult worm in portal vein, ova in urine or stool, meracidia in water, sporocytes in snails, cercaria in water, infects man by skin penetration. Circulatory system: adult worms in portal vein, and the cycle goes again and again. Pathogenesis: ova reach liver by portal vein tributaries lodged in portal tracts. These ova induce cell-mediated immune reaction with formation of granuloma. The ova are surrounded by lymphocytes, macrophages, and eosinophils, leading to periportal fibrosis and pre-sinusoidal portal hypertension. In pure bilharziasis, fibrosis, not cirrhosis. Patients with bilharziasis usually develop cirrhosis mostly due to post-hepatitis cirrhosis. Clinical picture: history of bilharzia dysentery, portal hypertension, liver cell failure, very rare as the hepatic architecture is normal in pure bilharziasis, but it may occur in mixed pathology with hepatitis C. Pulmonary hypertension and cor pulmonale may be present. Causes of associated hypoalbuminemia: decreased intake, nutritional deficiency, decreased absorption, malabsorption due to intestinal congestion, decreased production due to associated cirrhosis in mixed pathology, and finally increased loss from bleeding and protein losing enteropathy. Characteristic phases: wasted, dehydrated in the upper part of the body, while ascites in mid and edema in lower limbs, Spider-Man. Parotid enlargement, anemia due to malnutrition and bleeding with hypersplenism. Jaundice, very rare and mild. Liver, enlarged liver in early cases, not tender except in associated hepatitis or amoebic abscess, not nodular. Later on it becomes shrunken. Spleen, enlarged, may reach a huge size, first due to reticuloendothelial hyperplasia and later due to portal hypertension. Ascites may develop late due to associated hypoalbuminemia, and we mentioned the causes of associated hypoalbuminemia. Stages of hepatic bilharziasis: 4 stages: hepatomegaly, hepatosplenomegaly, shrunken liver splenomegaly, and ascites. Investigations to detect bilharziasis: investigations for portal hypertension, lefts positive in mixed pathology of the liver, investigations for cor pulmonale, X-ray and echo. Treatment: antibilharzial treatment, we're going to discuss it in bilharzial dysentery, treatment of portal hypertension, treatment of liver cell failure, and treatment of cor pulmonale. Then we're going to discuss cardiac cirrhosis. Etiology: due to long-standing liver congestion, it's rare and late. The etiology is right-sided heart failure, tricuspid valve disease, constrictive pericarditis and pericardial effusion, inferior vena cava obstruction, Budd-Chiari syndrome, obstruction of large hepatic veins, veno-occlusive disease, obstruction of small intrahepatic veins. Clinical picture: cardiac cirrhosis is rare and late, but we have general features of cirrhosis. Portal hypertension occurs before liver cell failure. Liver is enlarged tender, soft, then firm with sharp border. Investigations, same as cirrhosis. Investigations for the cause, echocardiography. Treatment, general measures for cirrhosis, treatment of the causes such as heart failure. Budd-Chiari syndrome, obstruction of large hepatic veins due to idiopathic, obstruction by tumor, or thrombosis. Thrombosis such as polycythemia rubra vera, OCPs, oral contraceptive pills, paroxysmal nocturnal hematuria, Behçet syndrome, atrial myxoma, and antiphospholipid syndrome. Clinical picture, acute stage and chronic stage. Acute stage, triad of abdominal pain, ascites, rapidly enlarged tender liver, manifestations of fulminant hepatic failure may occur. Chronic stage, features of cardiac cirrhosis, lower limb edema, and dilated veins over the abdominal wall and back. They suggest IVC obstruction. Investigations for Budd-Chiari laboratory, elevated liver enzymes and bilirubin, assessment of hypercoagulability state, imaging, CT and MRI for the abdomen, hepatic venography, diagnostic but invasive. So we have duplex ultrasound, which is the gold standard for diagnosis. And finally, liver biopsy. Treatment, long-term anticoagulant in chronic cases, thrombolytic therapy in acute cases, surgical shunt or TIPS, transjugular intrahepatic portosystemic shunt to divert blood flow around the obstruction. Needless to say, plus general treatment of cirrhosis, controlling ascites, hepatocellular failure. Liver transplant is effective for treatment of Budd-Chiari, but it's reserved for patients with fulminant hepatic failure. Then we have biliary cirrhosis. Cirrhosis caused by prolonged biliary obstruction. Bile is very irritant to hepatocytes if retained. We have primary biliary cholangitis and secondary biliary cirrhosis. Primary biliary cholangitis is a new name for primary biliary cirrhosis, autoimmune disease leading to destruction of intrahepatic bile ducts. Clinical picture, females 30 to 50 years, 10 times commoner in women than men. We have asymptomatic. In third of the patients, fatigue is the most common symptom. Itching occurs month before jaundice because of the retention of bile salts, which can occur before significant retention of bilirubin. Obstructive jaundice, clubbing, hepatomegaly, malabsorption of fat-soluble vitamins, vitamin D leading to osteomalacia, vitamin K leading to bleeding tendency. Associated immune disorders, SLE, 30% of patients have thyroid disorders, then melasma secondary to hypercholesterolemia. Complications of cirrhosis, liver cell failure, portal hypertension. Medical causes of itching, hemolytic anemia, obstructive jaundice, primary biliary cirrhosis, lymphoma, leukemia, polycythemia, diabetes, and chronic renal failure. Investigations, liver biopsy is diagnostic. Liver imaging, ultrasound, CT will show enlarged liver with no dilated intrahepatic biliary radicals. Liver function test, the most characteristic blood test at the elevation of alkaline phosphatase. Prothrombin, bilirubin, and albumin tend to be normal until late in the disease. Serology, autoimmune disorders. So we have anti-mitochondrial antibody or AMA positive in 95% of the cases. It is the most important diagnostic feature, but the TETR is not predictive of any outcome. And we have elevated IgM. Treatment, UDCA, secondary bile acid, is the first-line therapy, should be used in all patients regardless symptoms. Immunosuppressive, such as penicillamine and abatoprine. Symptomatic treatment, cholestyramine for itching. Liver transplantation is the most curative treatment. Cortisone is contraindicated because it increases osteomalacia and osteoporosis risk. Secondary biliary cirrhosis, extrahepatic, stone, stricture, cancer head of pancreas, usually of short duration, so cirrhosis usually doesn't occur. Intrahepatic, the same as obstructive jaundice, that will be explained later. Clinical picture, investigations, and treatment of obstructive jaundice, as we mentioned. How to differentiate between extrahepatic and intrahepatic biliary obstruction. In ultrasound, intrahepatic, constriction of intrahepatic bile radicals, but for extrahepatic obstruction, dilatation of the intrahepatic bile radicals, and by cortisone test, and also by the clinical differentiation. Then we have hemochromatosis or bronzed diabetes, autosomal recessive disorder. Responsible gene is HFE on chromosome 6. Hereditary disease characterized by excessive absorption of iron resulting in increased total body iron with its deposition in several organs. Etiology, excessive iron absorption due to absence of mucosal block. Autosomal recessive disorder. Body iron reaches up to 60 grams. The normal is from 3 to 4. Clinical picture, more common in males. Liver cirrhosis with increased risk of hepatoma, 20%. heart, cardiomyopathy, arrhythmia, skin, bronzed color due to stimulation of melanocytes, pancreas, diabetes, mental disturbance, testicular atrophy due to hypogonadism, adrenal failure and pituitary dysfunction, arthritis, most common in second and third metacarpopharyngeal joints, hips and knees. Investigations, lab, serum iron, ferritin and transferrin saturation are elevated, total iron binding capacity is reduced, liver enzymes are usually elevated. Transferrin saturation and ferritin are the two best tests for screening of a patient with risk of hemochromatosis. Liver imaging, abdominal CT and MRI. Liver biopsy is a gold standard for diagnosis. Treatment, symptomatic treatment, treatment of cirrhosis, and finally treatment of the cause. Repeated venesection or phlebotomy is the treatment of choice once per week because every bag of blood, 500 milliliters of blood, contains 250 milligram of iron with iron chelator desferol. Then we have hepatolenticular degeneration or Wilson's disease. Autosomal recessive disorders, the responsible defective gene is ATP7B on chromosome 13. In Wilson's disease, copper absorption is normal, but there is deficiency in hepatic formation of ceruloplasmin, which is the principal transport protein for copper and necessary for biliary excretion. So free copper will be released to the blood, leading to its urinary excretion and abnormal deposition in several organs such as liver, brain, and eye. Clinical picture, the majority of cases present between 5 and 35 years. Liver, hepatitis, self-limited, and it may progress to fulminant hepatic failure or cirrhosis. Eye, we have Kaiser-Fleischer ring, yellow ring around the edge of iris. Kidney, renal tubule damage, which leads to albuminuria and aminoaciduria. CNS, psychiatric manifestations in almost all cases, depression, psychosis, lentiform nucleus, basal ganglia, leading to extrapyramidal manifestations, including tremors. Investigations, we have reduced ceruloplasmin level, seen in 90% of the cases, reduced serum copper level, elevated urinary copper excretion with liver biopsy. The question is, who should be screened for Wilson's disease? Anyone with unexplained liver disease or neurological symptoms with evidence of liver disease. If diagnosed, the first-degree relatives must be screened as well. Treatment of the cause. Penicillamine increases urinary excretion of copper. Zinc, it blocks the absorption of copper. Restriction of copper in diet decreases by decreasing liver intake and mushrooms. Symptomatic treatment, and finally treatment of cirrhosis by liver transplantation. Acute fulminant hepatic failure. Definition: hepatic failure with encephalopathy developing in less than 8 weeks after the onset of jaundice in a patient without pre-existing liver disease. We have hyperacute liver failure, acute liver failure, and subacute. Subacute from 8 weeks to 6 months, acute within 2 to 8 weeks, hyperacute within 2 weeks. Etiology: viral hepatitis, alcohol toxicity, Budd-Chiari syndrome, paracetamol toxicity. The daily dosage shouldn't exceed 4 grams per day. When it exceeds 15 grams per day, this leads to liver injury, and if it exceeds 25, this leads to fatal fulminant hepatic failure. Mechanism: active metabolite of paracetamol is hepatotoxic. It's detoxified by glutathione, but when glutathione stores are depleted, severe liver damage can occur. Antidote is N-acetylcysteine. Acute fatty liver of pregnancy, rare, serious condition, occurs in the 3rd trimester or immediate period after delivery. It can be relieved by delivery of the infant. Abnormal fatty acids produced by the fetus pass to the mother, overcome maternal hepatic mitochondrial oxidation system, leading to accumulation of hepatocytes, accumulation of fat in hepatocytes. It's thought that it can be caused by dysfunction of fatty acid metabolism by mitochondria in the mother, caused by deficiency in the L-CHAD, long-chain 3-hydroxyacyl coenzyme A dehydrogenase enzyme. It's not important to know the name. It's L-CHAD, LCHAD. Ray's syndrome, rare but serious condition. Classic features are rash, vomiting, liver damage. Has been associated with aspirin consumption by children with viral infection, so children recovering from flu-like symptoms should never take aspirin. Clinical picture: encephalopathy from severe liver injury leading to increased ammonia and occurrence of other metabolic complications such as hypoglycemia, hypokalemia, sepsis, or brain edema. Coagulopathy leading to bleeding. Jaundice, mild in early stages and becomes deep later. The condition may be misdiagnosed as encephalitis. The condition usually ends by death due to bleeding, cerebral edema, respiratory and circulatory failure, shock, and other organ failure. Complications: encephalopathy, cerebral edema, one of the common causes of death in fulminant hepatic failure due to cerebral vasodilatation, respiratory failure due to pulmonary infections, aspiration in comatose patients, circulatory failure, hypotension and tachycardia due to vasodilatation, infection, bacterial sepsis 80% and fungal sepsis 30%, renal failure, sepsis, toxic, hypoxic or functional because of impaired production of urea, and blood urea doesn't represent the degree of renal impairment, metabolic, hypoglycemia, hypokalemia, hyponatremia due to water retention, hypomagnesemia, hypocalcemia, acid-base disturbance leading to metabolic alkalosis. Except for paracetamol overdose, we have lactic acidosis. Investigations: we have CT MRI of the brain to exclude brain lesions, liver imaging, small in hepatic necrosis, and enlarged in heart failure, viral hepatitis, or Budd-Chiari syndrome. Investigations for the cause: hepatitis markers, serum drug screen for paracetamol, liver function tests, serum bilirubin elevated exceeding 23 mg means poor prognosis. Serum enzymes ALT and AST are elevated and may remain high or fall later due to extensive loss of liver cells. Serum albumin normal, but later it becomes low if the patient survives for more than 3 weeks. And finally, prothrombin time is prolonged and it's used for assessment of prognosis. We have King's College Hospital criteria. For a case of paracetamol overdose, whether by pH less than 7.3 or all of those three, INR more than 6.5, prothrombin time exceeding 100 seconds, serum creatinine exceeding 3.4 mg per deciliter, or grade 3 or 4 hepatic encephalopathy. And for a case non-paracetamol acute liver cell failure, it's by INR exceeding 6.5, prothrombin time exceeding 100 seconds, or any three of the following, such as age between 10 and 40 years, unidentified cause or drug toxicity, duration of jaundice before hepatic encephalopathy exceeds 7 days, INR more than 3.5, prothrombin more than 50 seconds, serum bilirubin more than 17 mg per deciliter. Treatment of encephalopathy, treatment of complications, artificial hepatic support, charcoal filter to absorb toxins from the blood, and finally hepatic transplantation. And this concludes our part for today.